We're now going to discuss diarrhea followed by constipation. Diarrhea has multiple causes. The most common cause of acute diarrhea in children was going to be gastroenteritis or infectious. So you can see there on this table across the board, doesn't matter whether you're an infant, a child, or an adolescent, the most common cause of diarrhea in the acute phase is going to be gastroenteritis. In an infant, you also worry about systemic infections. For example, a urinary tract infection can manifest with diarrhea in the infant. And certainly antibiotics can cause diarrhea in any age group because of what they do to normal flora of the gut. In the child, again, gastroenteritis is number one. Look also for food poisoning. When they discuss food poisoning, or if they want you to think about food poisoning in the test, look for a common source for or an outbreak. So look for like the church picnic or something along those lines where there's a lot of people eating and several people will get sick with it, and then you can think along the lines of food poisoning. Also, systemic infection can cause gastroenteritis or diarrhea in a child. Similar with the adolescent. Chronic causes of diarrhea, in infant and children, you think of post-infectious problems. So they're getting over the gastroenteritis, and they kind of have like a bit of a milk intolerance. So it's a post-infectious lactase deficiency, and what happens is the brush border has been lost. They do not accept, the brush border causes the loss of the brush border causes a relative malabsorption, and the lactase contributes to, the lactose that they're taking in now contributes to the diarrhea. Also look for milk and soy intolerance in the infant, celiac disease, and always keep in the back of your mind cystic fibrosis in an infant. In the child, post-infectious lactase intolerance again because of loss of that brush border. Then also worry about celiac disease. Lactose intolerance actually increases with age. So that's why it's common in all three age groups. And then also in children, look for parasites like Giardia. In an adolescent who has chronic diarrhea, think of inflammatory bowel disease, and we'll cover that a little further on. Also, laxative abuse is a cause of chronic diarrhea in adolescents. Now you start thinking of psychiatric problems like anorexia, bulimia. Common causes of gastroenteritis in children. Think of viruses first, and the most common cause, viral cause of gastroenteritis, particularly in infants, is rotavirus, and it's much more common in the wintertime. Other viruses include the enteric adenoviruses. Also remember, they might give you a particular question and they might talk about the Norwalk virus. The classic setup for the Norwalk virus causing diarrhea is look for a cruise ship. And so various people in the cruise ship are coming down with diarrhea. Think of the Norwalk virus. In infants and small children, wintertime, think of rotavirus. Bacterial causes of diarrhea in children include Salmonella, Shigella, Campylobacter, Yersinia, and E. coli. A lot of these are going to be food transmitted. So for example, Salmonella, think of dairy products such as undercooked eggs, or raw eggs, undercooked poultry like undercooked chicken and turkey can cause salmonella. Also, salmonella can be caused by handling those little baby turtles that everybody gets at the pet store. So think of that as a cause of bacterial cause of diarrhea. Shigella, it can be a food or waterborne. Campylobacter you can sometimes get from playing with puppies. Yersinia is one that can cause a bloody diarrhea as well as Campylobacter and Shigella. So patient with bloody diarrhea, you should think of those causes. And E. coli, think of various sources. The common one that you're going to be asked is the E. coli 0157H7, which can cause hemolytic uremic syndrome. Look for the undercooked hamburgers, and that can cause a gastroenteritis. Then they start getting better, and they can go into renal failure and hemolytic uremic syndrome. There's a list of parasites there. Cryptosporidium is typically a self-limited disease in most immune-competent people, but in immunosuppressed people like HIV/AIDS patients, it's a very chronic diarrhea. It's almost impossible to get rid of it. Always look for parasitic ask about well water versus city water. Well water may be contaminated and can cause giardia, for example. Trichuris can cause also gastroenteritis. Questions that you need to be looking for are exposures. So look for a patient that goes to daycare. Very high risk when a baby goes to daycare to get some kind of infectious gastroenteritis. Also recent travel to other countries, again water supply, that sort of thing. Use of antibiotics. If they start talking on the exam about prior use of antibiotics, right away you should think of Clostridium difficile as the cause of the diarrhea. That's like a knee-jerk response. Look for other known exposures, also particular intake of, for example, seafood or unwashed vegetables that might lead you along the road as to the etiologic agent. Management of diarrhea is basically, for the most part, hydration and rehydration. And certainly you want to prevent spreading of that to other contacts. So when you're taking care of a patient with diarrhea, always wash your hands. So always wash your hands before and after any patient contact. The etiologic agent may necessitate treatment. Typically viruses, you'll leave them alone. You do not need to give antidiarrheal medications. That might slow down the amount of stools, the number of stools. You're just going to have fewer stools, but they're still going to be extremely watery, probably more so than if you had not taken the medication. We do not want to use antidiarrheal compounds because it could be masking other problems also. The best test for diagnosing the cause of the diarrhea, look for the stool exam. So you can send the stool exam with a patient with acute gastroenteritis. You can find mucus, blood, white blood cells, a stool culture, also a stool for ova and parasites, helpful. The stool culture can, for example, show E. coli. The ova and parasites obviously can maybe a giardia. And also, again, if they talk about a patient who's been on antibiotics and you suspect C. difficile, then send for C. difficile toxin in the stool. You can also do enzyme immunoassays, and that kind of helps. For example, with rotavirus, there's a specific stool enzyme assay that you can order. Chronic gastroenteritis, you think of a different type of differential diagnosis now, and so these patients you need to specifically look for weight, height, and nutritional status. And that helps you as to determine the seriousness. If the weight, height, and nutritional status is normal and there's no blood in the stool, this is probably just a chronic, non-specific diarrhea. Sometimes there's what we call irritable bowel disease. There's also chronic diarrhea of infancy. These patients have, for example, with chronic diarrhea of infancy, they're gaining weight well, they're looking fine, they look very well hydrated, they just have lots of diarrhea, and typically it goes away on its own. Ask about a history of excessive fruit juice. For example, apple juice can cause an osmotic diarrhea. Also look for low fat intake. If the diarrhea can be studied for carbohydrates, and that lets you know that you have some kind of malabsorption problem of carbohydrates. If the patient has weight loss as part of their exam in the chronic diarrhea, do a stool for fat content. And if it's high, that tells you that they have some sort of fat malabsorption. And here is a workup for chronic diarrhea. First of all, a good history and physical, also a nutritional assessment, and some non-specific actually tests include the stool studies, which may be helpful as far as a culture over in parasite, CBC, to look for anemia, for example, a SED rate for inflammatory bowel disease. Those are the kind of things that you need to think about. Also, you can, as a second line tier of evaluation, think of a sweat chloride because of the malabsorption that many times goes along with cystic fibrosis. And then certainly stool collection, 72 hours for fecal fat for fat malabsorption. The more invasive tests are left for later as you get possibly negative results with your first line and second line of drugs. Then you can go to more invasive procedures. Malabsorption can present in a couple of different patterns. One is malabsorption from birth. The other pattern is malabsorption after introduction of a new food, which is why we say that when you're introducing new foods to the baby, to do one new one at a time, like one a week. That way you know what the reaction is going to be. You can pinpoint it to that particular food. Typically with malabsorption, the first thing that's going to be affected will be the decrease in weight. So they'll start showing some weight loss or poor weight gain, and then they will have a deceleration in their height velocity. And if it's really truly chronic, then the head circumference may start to slow down also. The initial evaluation of malabsorption, the best screening test is a stool for fat. The confirmatory test, which is the best, so you can do a spot stool for fat, but the best confirmatory test is a 72-hour stool for fecal fat. And you're going to see this a lot in patients that have pancreatic insufficiency. So for example, a patient with cystic fibrosis. If they have that and it's elevated, you absolutely should do a sweat chloride test to eliminate, rule out, or rule in cystic fibrosis. Also, a screening test is serum trypsinogen, but basically look for the stool fat first, then the 72-hour stool fat, and a sweat chloride. Gold standard for malabsorption is going to be the secretin or the cholecystokinin stimulation test, and you can analyze the duodenal content. So this would be your stepwise approach to this patient. Screening for carbohydrate malabsorption, look for reducing substances in the stool. And the stool pH will be less than 5.6. The definitive test for carbohydrate malabsorption, that sounds like a test question, is going to be the breath hydrogen test. If you're worried about protein loss in the stool, or what we call protein losing enteropathy, then you should do a spot stool for alpha-1 antitrypsin levels. Remember that for the exam. So you're going to be screening the stool for losses of fat, losses of carbohydrate, or losses of protein. This is a differential diagnosis for malabsorption, and Giardia can cause, as an infection, it can cause an acute diarrhea, but it can also cause chronic malabsorption. Remember, for Giardia, what's called the string test, or the duodenal aspirate. And that would be a test to help you confirm the diagnosis of Giardia, although you can also see for ova, cyst, and parasites, you can see stool for Giardia. HIV can also cause a chronic malabsorption. When it comes to the small bowel, look for gluten enteropathy. Typically, you will have a history of chronic diarrhea starting at around the time that gluten is introduced into the diet. If you are thinking of pancreatic insufficiency as a cause of malabsorption, right away cystic fibrosis is at the top of the list. Malrotation can sometimes be causing malabsorption. You can have incomplete obstruction and malabsorption. That means that you're going to be having some diarrhea going through. Think of malrotation at that point. And there's something called short bowel syndrome. For example, a patient that has had bowel removed, let's say a baby that had necrotizing enterocolitis with severe ischemia and has had to have bowel removed, and then a reanastomosis. These patients will have decreased absorptive capacity of the intestines, and therefore they have chronic diarrhea. This is Giardia lamblia cyst, which can be seen in the stool. Celiac disease is a cause of malabsorption, and it's a chronic cause. And look for, again, relationship to the diet. So when gluten is introduced into the diet, that's when the patient will start to have malabsorption. And gluten-containing products are rye, wheat, and barley. Usually at around 6 months to 2 years of age is when you start introducing these things, and that's when you start seeing celiac disease. These patients will have, again, failure to thrive or malabsorption and poor weight gain because of that. And it is associated with the HLA locus at DQ2. Clinically, they'll have chronic diarrhea, failure to thrive. They can have vomiting, anorexia, no interest in feeding, to become somewhat apathetic. The evaluation, a very good screening test is going to be both. These have to be together, the anti-endomysial and anti-gliadin antibodies. The two of those together are almost 100% positive and negative predictive values as a screening test. But the gold standard is going to be histology, so that requires an endoscopy with biopsy, and then you look at it histologically, and that gives you the diagnosis of celiac disease and its dietary management. This is one of the manifestations of celiac disease, the dermatitis herpetiformis. You can see it all over this patient, all of these lesions. Okay. This is another patient with celiac disease, and you can see that they have bloating. That's not that that's just bloating. He's not very happy. And look at the muscle wasting and the loss of fat. So look at the buttocks, and there's very little fat there. And that's typical because they have failure to thrive from their chronic malabsorption. Other causes of malabsorption, Shwachman-Diamond syndrome. These patients act almost like cystic fibrosis in that they have a pancreatic insufficiency, but they also have a neutropenia. So a CBC is helpful there in showing the neutropenia. And these patients are at higher risk for infections. Lymphangiectasia, intestinal lymphangiectasia, can also be associated with malabsorption. And certainly a disaccharidase deficiency, if you don't have the enzyme, you can have malabsorption. And lastly, the A-beta lipoproteinemia. That causes severe fat malabsorption manifested as chronic diarrhea, and this occurs from birth.